Just let me know that the slides are up.
Okay, cool. Alright. Hi guys. Thank you so much for coming. So yeah, I flew in all the way from Mildura because I really wanted to see you all and wanted to do this lecture. So that was nice. I can see like all the private school Melbourne kids in Mildura. Like Calvin, Mildura is like a small town. It's like a rural town. Yeah. And like I don't know if you guys can tell I'm from Mildura. It's a Monash School of Rural Health Cup. But anyway, so how was your last year semester? Good. Sinead's really happy it's holidays. Yeah. So like before I start the lecture, I just wanted to like say hello to everyone. And like I just want to say everyone looks so stressed at uni, and I'm genuinely so worried. Like everyone just sends me snaps about how miserable life is. I have my ways, and yeah, just please be happier during holidays. Don't stress about exams; they'll come and go. And then there's some things that are just like weird and wonderful, and just need a little bit of explaining. And like I was just so confused. Sinead, did you get your Mikey back from the toilet, or is it okay? Perfect. Oh, great, perfect. It's brand new. Amazing. And then yeah, then like I see interesting Facebook things, and I don't know if Vinith is here. I don't know if she's here, but like there's 2 comments with her name. Like that really needed some explaining. It's so sad she's not here today, but someone passed the message on. Like yeah, like it didn't make much sense. Yeah. But then I'm scrolling through Facebook and then something worse turns up. No, like the first 2s are lovely, I'm sure. And then like obviously the Annika and Aditya like snaps, always gonna have those there. And the perfect squad, like honestly, this is gold. And once again, just some things that need explaining, and it just doesn't make sense. And then Ella Ryan, like look at you go. Impressive. Anyway, that's enough. I think I've roasted you guys enough. So I'll start with the actual lecture now. So it was just like a little like spiel at the beginning because like obviously it's the last day and I want this session to be relatively chill. I don't want it to feel like a proper lecture. But anyway, welcome to endocrinology. How many of you actually like endocrinology? Oh, that's not very many. Okay, well, today I'm going to be going through these things, except I'm probably going to skip out on the pharmacology and clin skills simply because I looked at pharmacology and it seemed fairly straightforward. And with clinical skills, I did that yesterday with the Oskinite thing, and I'll post all the notes up for that as well. I'm pretty sure Minoj has them. Oh, perfect. And in terms of exam contribution, now, before you guys might have been used to like immunology, microbiology, now that it's endocrinology, you'll actually have things from anatomy, pharmacology, physiology, and clin skills. So that's why there's reason to like endocrinology now. But moving right along, so with the endocrine system, obviously it affects a lot of different body systems. And in Med 2031, they generally cover these systems. So the hypothalamus, pituitary, parathyroid, thyroid, adrenal glands, and the pancreas. So we'll try and cover all of that today. And we'll start with anatomy and embryology. So, do you guys remember how last year when I did a revision lecture, the ones that attended, someone's name would pop up and they'd answer a question? Well, I hope this person's here. Is Anisha here? No? Oh, sorry. Is she here? She's not here, is she? Oh, there she is. Hello, how are you? Do you want to answer a question? I promise these are like, there's no trick questions. I don't do trick questions. Yeah, perfect. Look at you go. Okay, good. Right here. So let's get started. So this is like a cross section of the brain. I know you guys haven't done neuroanatomy, but just to put it in context, this is where the pituitary is, just in that middle section there. So the pituitary and hypothalamus, it's a pea-sized structure that is connected to the brain by something called the infundibulum, and it's sitting within a depression in the sphenoid bone, which is kind of like in the skull somewhere. You guys don't need to know details about that now, but it sits on something called its sella turcica, and it contains 2 distinct halves that actually have different functions. So we have the anterior pituitary, which develops from Rathke's pouch, and it secretes 6 different types of hormones, which we'll talk in detail about later. And once again, I don't know how much detail they expect you to know, but they actually have different regions within the anterior pituitary. So you have something called the pars anterior, pars intermedia, and pars tubularis. And I guess it's important, these will become more important when you do neuroanatomy, but it's important that you know these concepts now. Then there's also the posterior pituitary, which develops embryologically from the forebrain. So since it actually develops from that embryonic brain, it contains connections to the hypothalamus directly and actually contains nervous tissue. Does this all sound new, or is this stuff you've covered? Oh, perfect. Right, thyroid gland. So this is actually located on the anterior aspect between C5 and T1. And some of you guys yesterday at the osteonite would have palpated that thyroid for the first time. And honestly, it's quite difficult to feel a thyroid. But once you get the practice of it, you'll eventually understand where it's located. The thyroid contains a left and a right lobe, which is connected by something called the isthmus. And it receives extensive vascular supply and embryologically develops from something called the primitive pharynx. So this is kind of like the tongue area. So it descends into the neck from the tongue and then ends up in its adult position in the neck. So often you'll come across thyroid pathologies where, like, you know, your thyroid exam, you stick your tongue out. That's because you could have something called thyroglossal cysts, which can sit in the tract that the thyroid descended down. And if those areas become cystic, then they'll move when you move your tongue because they want these to be connected. Does that make sense? Cool. Great, moving on to the parathyroid. So these are endocrine glands located on the posterolateral surface of the thyroid, but still located on the anterior neck. So if you imagine that this, so if this is the thyroid here, we're kind of looking at the back of the thyroid, and the actual parathyroid glands are these bits just here. Does that make sense? I only figured this out like end of last year as well, so I was like, shit. But anyway, so these guys regulate calcium in the body, and usually there's 4 of them, but obviously this can vary between people. Like these guys will make a lot more sense when you do head and neck anatomy, but embryologically, it's kind of weird, but the superior parathyroid glands actually come from the 4th pharyngeal pouch, and inferior parathyroid glands come from the 3rd pharyngeal pouch. Now, you don't need to worry about what a pharyngeal pouch is, to be honest, at this stage. Just know that it's there. And just know 3rd and 4th, because that can come up. But you'll study the whole head and neck embryology later next semester. Adrenal glands, so these guys are located on top of the kidneys. They're kind of like little hats on top of kidneys. And they contain 3 main layers. You've got the fibrous outer layer, the cortex, and the inner medulla. And we'll go into more details about what each of the layers do later on. So in terms of where they are, I just thought this was funny because I did your renal lecture, but maybe I was drunk while making this, but anyway. So this is where the adrenal glands are sitting, and note how they actually look separate in shape as well. So the right one's actually more pyramidal and the left one's more semi-lunar, apparently. Great, let's move on to physiology. Oh, who's next? Oh, Jamie. Hello, how are you? That's good. I'm all right. All right, your question. What endocrine organ secretes parathyroid hormone? Once again, no tricks. I don't do trick questions. Parathyroid hormone. That's okay. So a parathyroid hormone, if you take away the hormone, pretty much so, it's the parathyroid. Yeah, I'll give that one to you. So yeah, pretty much you've got the autonomic and endocrine systems, and these guys communicate with each other. So both the endocrine and nervous system communicate with each other through different mechanisms. And by that, the best example I can give is something like, for example, a state of stress. So you get activation of your sympathetic nervous system that's going to cause tachycardia, that's going to cause vasoconstriction on your skin, that's going to increase your respiratory rate. But at the same time, we might get release of cortisol, and that cortisol is going to help make sure that we have enough metabolic changes as well in the body that can help keep up that sympathetic drive. So that could mean making sure that there's enough sugar in the blood. So that's how they kind of work together. There's this table that is kind of almost directly from your lecture slides, and it kind of shows the differences between the 2 systems. I'm not going to read each difference out loud, But just note how the endocrine system kind of works on everything. It kind of just secretes everything into the circulatory system, and it goes and acts on all these peripheral tissues, whereas the nervous system is often more compartmentalized. That's how they describe it. Make sense? Cool. Hormone and hormone receptors. Now, this is that random lecture that most people skip over, but questions about this can come up. So there's various types of receptors and hormones. The two main types are peptide hormones that have a short half-life and are generally stored in vesicles as precursors. So an example of that is insulin being stored as C-peptide. Have you guys heard of that, C-peptide insulin? Okay, perfect, great. And steroid hormones, these are generally synthesized from cholesterol, and because they're synthesized from that, they're more lipophilic and hydrophobic. And so they generally travel all the way into the cell to act on the receptors because they're able to cross that plasma membrane really easily. Also remember that receptors can be found on the surface in the cytoplasm or in the nucleus itself. And this will correspond to where the hormone binds as well. So peptide hormones, because they're quite hydrophilic, they'll generally tend to bind more on the surface rather than into the cell. Make sense? Any questions at this point? Great. So looking at neurosecretions, we have the supraoptic and paraventricular nuclei that are located within the hypothalamus. And these guys send their axons down into the posterior pituitary. And the axons of these nuclei contain ADH and oxytocin, which can be released into the circulation when they get the appropriate stimulus. And on the other hand, we have parvicellular neurons in the hypothalamus that control anterior pituitary secretions. So these guys actually secrete hormone into the surrounding vasculature, and that's detected by the anterior pituitary. And based on the hormones it detects, it releases its own hormones that can act into the peripheral tissues and peripheral organs. Make sense? Cool. So this is just a diagram showing what I've said, but pretty much you can see that here we've got the paraventricular nucleus and the supraoptic nucleus, and they have their axons directly going all the way down into the pituitary and then releasing their hormones within the bloodstream. Whereas with your, so within your anterior pituitary, you've got your parvicellular neurons that are sending their axons into the bloodstream, releasing hormones, and then these hormones are detected by the anterior pituitary, and then the anterior pituitary releases them. Make sense? Cool. So I'm sure you guys would have seen a diagram like this some stage during your lectures that shows the hormones that are present in the hypothalamus, how they're affecting anterior pituitary hormones, and what effect the anterior pituitary hormones have on the rest of the body. This is a fairly straightforward diagram, but there's two things you really want to be aware of, and that's growth hormone and prolactin. So with growth hormone, it's a bit special because it has both, it has growth hormone releasing hormone, which will help stimulate release, and also has somatostatin, which will help decrease release. With prolactin, that one's interesting because it only has dopamine, which inhibits prolactin release. So the other ones are fairly straightforward because that hormone will help stimulate release of the next hormone, if that makes sense. Cool. And once again, this diagram kind of summarizes everything we've just talked about. It's got that anterior and posterior pituitary, and then acting on the peripheral tissues. Now, this is a fairly overloaded diagram, but if we just look at the bottom section here, we can see that on the thyroid, we're going to have TSH releasing thyroid hormones, ACTH with cortical hormones, FSH, LH, and prolactin will help release all your reproductive hormones. These guys will come more into play next semester when you do reprofizz, but for now, know that they exist, but I guess you don't need to know the details of how these guys actually work and how testosterone and all of that is produced. And then you're going to have growth hormone acting on insulin-dependent growth factor receptors, and that's going to help with bone, muscle, and adipose tissue development. Make sense? Any questions? Calvin, you look very happy, and I don't know why. Oh, perfect. Cool. Hormones of the posterior pituitary. So with this one, it's a similar concept, but there's actually fewer hormones involved. So we have oxytocin that stimulates milk letdown and uterine contractions, as well as a whole range of other psychiatric changes as well. So the example I think they talked about in the lectures is the mechanoreceptors on breast tissue that send signals to the hypothalamus during suckling, and that's going to cause release of oxytocin and activation of the supraoptic and paraventricular nuclei, and that oxytocin is then going to act on that breast tissue to let milk let down. At the same time, ADH also works in a similar way. So you guys would have heard of ADH in renal physiology. That's the hormone that helps insert channels into the tubules to help with water reabsorption. So let's say if you're super dehydrated, you're going to get increase in plasma osmolarity. That increase in plasma osmolarity is going to get detected by the hypothalamus, by the osmoreceptors, which will then send signals to the hypothalamus and cerebral cortex. So the hypothalamus is going to be like, great, I need to release ADH because my plasma osmolarity has gone too high. The cerebral cortex is going to make you feel thirsty. And both of those mechanisms combined will help retain that water from the kidneys and help restore homeostasis. Make sense? And that's all of that summarized in a diagram form if you're more visual learners, but I'm not going to go through the same thing again. Cool. It's a bit full on, isn't it, the diagrams? But they really explain everything so well. Great. Okay, feedback loops. Now this concept is fairly stressed throughout the entire endocrinology series. I'm not going to dwell on it too much, but pretty much know that there are feedback loops in place that help maintain homeostasis and make sure that there isn't too much or too little of a hormone. And the example they've used here is, I think, the androgen. So you've got the hypothalamus affecting the pituitary, and then you've got testosterone production in the end, and that's going to go and negatively feed back the other organs to stop secreting hormones. Make sense? Perfect. So thyroid hormone production, we thought it wasn't that important, but often it does come up, turns out. So maybe know the basic steps of what's involved. So pretty much we're going to have follicular cells containing sodium iodine transporters that help grab iodine from the plasma and grab it into the cell. Through various processes, we eventually get secretion of thyroglobulin into the colloid, which is like a storage unit in the middle of the thyroid tissue. And then we're going to have tyrosine bits on the thyroglobulin become iodinated, and they'll either produce an MIT, so that's only if one iodine is attached onto the thyroglobulin module, or a DIT, which is when two iodine molecules are attached. Then these thyroglobulins will then combine together and form either T3 or T4. So if an MIT and a DIT combine, it's T3. If two DIT molecules combine, it's a T4. And then these guys will get endocytosed back into the cell where they'll get cleaved and become activated. And that's when they can be secreted into the bloodstream and act on peripheral tissues. But that's based on signals they receive from the pituitary gland. Does that all make sense? Great. And this is, I think, the diagram the lecturer used as well, except hers was super pixelated. So I thought I'd grab one that wasn't as pixelated because I honestly couldn't read it when I put it in my notes. Like, it was too difficult. But pretty much same thing here. We're going to see iodine entering the cell, thyroglobulin being produced. This is the colloid here. It's going to sit in the colloid until we need formation of that DIT and NIT and T3 and T4. We can see that T3, T4 come out here and then into the bloodstream to act on peripheral tissues. Make sense? Cool. There are some differences between the different thyroid hormones. It is important to know them, but like, once again, I'm not going to run through each of these because you guys can read that on the slide. The main thing you really want to know is that we have more T4 than T3, and that's because T3 is way more potent than T4. Clinically, we generally only test T4. There are some cases in some pathologies where we might test T3, but I don't think they test you on that in year 2 anyway, so don't worry about it. But remember, T4 is super important, which is why we still need to know the difference between them. Great. Thyroid hormone and receptors. So the way the thyroid hormone works, it's actually kind of interesting because it goes all the way down into the DNA and then attaches onto receptors to cause gene transcription changes. And once these transcription changes have happened, that's when you'll get that changes in that organ's function. And just remember, like any other hormone, thyroid secretions are dependent on a whole range of things. So things like your circadian rhythm will affect when you release your thyroid hormone, and as well as environmental influences. So if you're ridiculously cold, you'll have more thyroid activation because it's going to increase your basal metabolic rate so you can get more body heat. Great. Didn't you love that sound effect? Oh, you missed out last year. I called it funny. Yeah, that's all right. We'll ask you this time. I made it extra hard because you weren't there last time. No, it's not actually. Once again, no trick questions with me. Does increased thyroid hormone levels make the heartbeat faster or slower? It's not a trick question. Faster, perfect, great. So the thyroid hormone does like absolutely shitload of things that is very difficult to remember. I've got kind of like this table here that kind of shows the system that's affected, how it's affected, and what would happen in hyper and hyperthyroidism. Now, this is a massive table that you guys can go through in your own time if the need be. But basically, you're going to get changes in your basal metabolic rate, where you get promotion of normal oxygen use. In terms of your macromolecules, you're going to get glucose catabolism, mobilization of fat. Pretty much, you're going to burn energy. The nervous system, it promotes normal development. Cardiovascular promotes normal development. Muscular system promotes normal muscular development. And with hypo and hyperthyroidism, you can get weakness in these muscles. Skeletal muscle, once again, promotes normal development. Gastrointestinal system promotes motility. So with hyperthyroidism, you'll get a diarrhea. Hypo, you'll get constipation. Reproductive system, you don't need to know for now, but helps with reproductive development ability. And of course, you're going to have your skin that promotes hydration and secretory activity. So people with hypothyroidism are often very sweaty. People with hypothyroidism often have very dry skin. You'll notice that a lot of this says promotes normal growth, normal function. And that's because the thyroid hormones are super important during development. So I think the lectures might have talked about cretinism, which is when kids are born when they don't have enough thyroid hormones. And they often have a lot of intellectual disabilities or physical disabilities because the thyroid hormones were unable to perform these functions. Make sense? Cool. So moving on to the adrenal cortex. So there's three layers that we've talked about. There's the glomerulosa, fasciculata, and reticularis, and this is in the cortex. So then there's the separate capsule and there's a separate medulla. Now, the outer zone secretes mainly aldosterone, but both the fasciculata and reticularis actually secrete cortisol and androgens. The difference is that the reticularis maintains chronic basal levels, whereas the acute increases in ACTH is detected by the fasciculata, and that secretes the extra on top cortisol and androgens. So does anyone use that salt, sugar, sex acronym thing? No, don't use it. It's actually salt, sugar, and sex sometimes. Sugar and sex all the time, which ruins it, I know. But I mean, if you want, you can use that one. But if you want to do endocrinology, don't use that one. Yeah, like it's just something that can catch a lot of people out. I don't think they had a question on this last year, but they've known to have questions in the past where they know students like to use GFR, salt, sugar, sex, and then they caught people out because one of the options was like the fasciculata secretes sugar and androgens. Cortisol and androgens. So, yeah. Does that make sense? I mean, you can use GFR. In your histo, they use salt, sugar, sex. Like, that's how they describe it. But physiologically and in real life, that's kind of how it is. So, sorry, it kind of ruins the acronym. Feel free to come up with new ones. But anyway, so ACTH, this is a hormone produced by the pituitary that regulates steroid levels by binding to melanocortin 2 receptors on the adrenal gland. And due to its structural similarity to other molecules, it can actually bind to melanocortin 1 receptors as well. And so that's why when you get ridiculously high amounts of ACTH, you can actually see skin hyperpigmentation. And because the adrenals have to work harder, if there's more ACTH, you might also get adrenal hypertrophy. Does that make sense, the whole hyperpigmentation thing? Great. Actual glucocorticoid production is interesting as well because cortisol is the endogenous glucocorticoid produced by the body during stress and states of hypoglycemia, cold exposure, pain, and all that sort of stuff. And cortisol is highest on waking, which is why often if you want to have an ACTH or a cortisol test, you ask your patient to do it relatively early in the morning because they change so much during the day. You don't want that variation. Due to structural similarity with aldosterone, cortisol can act on mineralocorticoid receptors as well if the levels are exceptionally high. And that's why you can actually get sodium resorption in the kidney and potassium excretion when you have ridiculously high cortisol levels. Being a steroid hormone, it actually binds to receptors within the cytosol by translocating and then translocates into the nucleus to activate gene transcription. Does that sound new, the whole cortisol acting on mineralocorticoid receptors? Okay, perfect. It's been mentioned. So okay, good. So this is a revision lecture then, from most of us. Great. Actions of glucocorticoids is fairly complex because they work on absolutely everything. And I remember the lecture including ridiculous diagrams of all the different arrows and where it's working. But I kind of broke it down into three things. So metabolic actions, and that was mainly catabolic, so to increase blood glucose levels. There's the hematological action, so that's suppression of the immune system. And then finally, you can have other actions, which is a bit of a cop-out, but that's bone, brain, heart, hypotension from acting on mineralocorticoid receptors. So you're going to retain more salt, and that means you're going to retain more water. That means you're going to have high pressure within the blood. Fetus, so it promotes cellular differentiation and growth. It actually inhibits growth in children. So that's one of the reasons why you wouldn't give long-term steroids to children because it can affect their growth. Yep, and speaking of actions of glucocorticoids, there's, in terms of the metabolic actions, they're important to know in more detail. So we firstly have ketones, increased production of ketones, and that's because we're going to start using things other than glucose to supply the body with energy. And going back to Med 1011, remembering that ketones is one way that we can get energy sources from one part of the body to another. Glucose, we're going to have increased uptake. Even though we want hyperglycemia, we also want cells to use up all that energy. So often because cortisol is released in states of stress. So we want the cells to have enough energy as well. So you actually get increased glucose uptake, but at the same time, we also have other mechanisms that are trying to increase blood glucose levels. Yes? It is a form of energy as well, and that's because we're trying to increase every form of available energy. Yeah, so because there'll be some tissue, so going back to Med 1011, you guys will remember that there's some things that will use just glucose, some things that will use just fat, some things that will use just ketones. The body's trying to make sure that all energy sources are available so that all the organs in the body have sufficient energy stores. Perfect. Lactate, so once again, another energy source for the body. We're going to have mobilization of fat deposits, and we're going to have increased protein catabolism as well. Now, one thing to know about the fat deposition is that even though we get mobilization of fats, in some parts of the body, especially the abdomen and the face, we'll actually get deposition of adipose tissue. So, and generally the fat that's mobilized is from the arms and legs. So if you look at this diagram here, this is kind of all the different actions of glucocorticoids summarized. You'll see that here, you'll see fat deposition, but only centripetal or central fat deposition. All other fat is generally mobilized. Make sense? Cool. What else was there in this slide that was interesting? Nah, nothing much. Oh, osteoporosis. Remember that it can also cause bone resorption. So people with really high cortisol levels can get osteoporosis. So once again, I've got a table that kind of summarizes mineralocorticoids, glucocorticoids, your androgens, and your catecholamines, so all the things your adrenal glands secrete. So mineralocorticoids, you would have done all of that in nephrology just before endocrinology. Glucocorticoids we've covered now, and the androgens you're going to cover next semester, and catecholamines is all your adrenaline, noradrenaline, which you would remember from Med 1022, sympathetic nervous system stuff. So that's kind of adrenal glands done for you guys. Does that all make sense? Any questions about the adrenal glands? They're quite powerful for such little things. So impressed by them. But anyway, don't judge me. All right, growth hormone. Moving on to those guys. So these are fairly complex, but they've kind of simplified it down for the course, fortunately. But obviously, a lot of the times, growth hormone might not make a lot of sense, and that's okay because it's just so complex of how it works. And also because a lot of people don't know a lot of its actions. So obviously we have the growth hormones that are super important for growth itself, but at the same time we have insulin-like growth factor hormones as well, which are secreted by the liver in response to growth hormones. So kind of like, you know how you get T3 and T4 release from TSH, you get IGF-1 release from growth hormones. And these are produced by somatotropic cells in the anterior pituitary. So in the anterior pituitary, we're going to get release of growth hormone in response to growth hormone releasing hormone and somatostatin. So remembering that one of them positively causes one to be released and somatostatin inhibits it. And then growth hormone can act onto the liver to produce IGF-1. Note that all these hormones still negatively inhibit each other. So we can see that IGF-1 is inhibiting growth hormone release, but it's having a positive action on somatostatin because somatostatin will decrease growth hormone release. Does that make sense? It's a bit of a mouthful, but yeah, people are nodding. Perfect. And at the same time, we have some random guy called ghrelin that's coming from the stomach. And during hunger, apparently this stimulates growth hormone secretion. I'm not actually sure why. And I remember someone asked our lecturer, so do you guys have Yvonne as your lecturer? Yeah. So someone asked her during the lecture why that happens. And even she was like, I have no idea. But apparently during hunger, we're going to get ghrelin release from the stomach. And that tends to act on the pituitary and cause increased growth hormone release. Don't know why. In terms of growth hormone action, so once again, I've got really crappy mnemonics here, but I used growth hormone receptor as the way I remembered it. So growth is glucose, so hyperglycemia, hormone, height, bone growth, and receptor RIP, so protein synthesis. And this is just a diagram that's kind of summarized it. Here. Great. So looking specifically at IGF-1, similar to how I discussed TSH causing T3, T4 release, growth hormone is going to cause IGF-1 release. And that's going to act on peripheral tissues, so mainly the liver, and then, the growth hormone acts on the liver, and then the liver will secrete IGF-1 that will end up acting on bone. So specifically, it'll go to the chondrocytes. So it does something quite interesting. It actually tells the chondrocytes to start dividing, but at the same time, it tells the chondrocytes to also produce IGF-1. So then there's a ridiculous amount of IGF-1 there, and all these cells start to proliferate and end up causing an increase in bone burn. Does that make sense? Cool. In terms of interaction, so to make things more complicated, growth hormone actually interacts with multiple other hormones too. I've kind of summarized the actions using my own terminology of positive, simultaneous, or negative interactions. But for example, both the thyroid hormone and growth hormone are required for brain development. So they have a positive interaction. So you guys will remember that table that I showed moments earlier where it was like promotes normal muscular development, cardiovascular development, neurological development. That's because these guys are working together to try and aid normal development. Sex steroids and growth hormones are both increased during puberty, and estrogen actually promotes epiphyseal plate fusion in bones. So it helps kind of finalize your bone length in the end. But they don't actually interact too much with each other, so it's a simultaneous interaction. And then insulin and growth hormone love interacting with each other. So insulin secretion actually promotes growth hormone activity. And once again, that's why they have a positive interaction. Glucocorticoids and growth hormones are interesting because they have a negative interaction. So once again, I don't know if you guys remember me mentioning that glucocorticoids are avoided in children, and that's because they stop growth. And that's because somehow they actually inhibit growth in most tissues, these glucocorticoids. So they have a negative interaction. Make sense? Cool. So yeah, for the exams, I kind of just learned positive interaction, simultaneous, positive, and negative, and that was enough. But I've got extra detail there if you're interested. Parathyroid hormone. So this one is unfortunately the one that causes the most confusion between people. It's kind of underestimated, I feel, unfortunately, but it's really important for actually calcium regulation. Your parathyroid hormone increases bone resorption to restore our normal calcium concentration. And when calcium levels are too high, they actually bind to G receptors within the parathyroid gland that helps cause inhibition of parathyroid hormone release. Vitamin D3 is also super important for parathyroid hormone synthesis. It inhibits parathyroid hormone synthesis. In terms of the actions of the parathyroid hormone, mainly acts on two main things: the kidney. It increases calcium resorption and subsequent decreases in phosphate reabsorption. So it increases calcium levels but decreases phosphate levels. And at the same time, it also increases hydroxylase activity. So this is an enzyme that converts vitamin D into its active form. So you're getting more vitamin D, the activated form, you're getting more calcium, and you're getting less phosphorus from the kidney. And that makes sense because we have low calcium. We want to increase our calcium reserve. So that's how it's done. And secondly, it acts on bone. So it increases osteoclast activity, and that causes breakdown of bone, and this bone that's resorbed is then released into the bloodstream as calcium, restoring that normal level again. Vitamin D is particularly important for calcium regulation in the body, but it must be converted into its active form, as we've just discussed, and that's called calcitriol. So it must go through the liver and kidney to do this, and specifically there's an enzyme called alpha-1 hydroxylase. I don't know if it's here. Oh, it's not here, but it's kind of like in here, this enzyme. And that enzyme is super important for that activation process. So this is vitamin D in its full name, and then this is the activated version of it. And as you would imagine, once your plasma ion concentrations normalize again, remember that this calcium is going to bind to G receptors within the parathyroid gland. That's going to inhibit parathyroid hormone release, and that's going to then inhibit enzyme activity as well. So it's all kind of regulated well together. Great. In terms of the actions of vitamin D, it's fairly similar to parathyroid hormone, but also slightly different. So in the kidney, this time it's actually increasing both calcium and phosphorus reabsorption, remembering that parathyroid hormone only increased calcium reabsorption. In the gastrointestinal tract, vitamin D actually helps increase calcium and phosphorus reabsorption as well. And lastly, in bone, it stimulates osteoclasts again to release calcium and phosphorus. So you guys would remember this diagram from Yvonne's lectures if she hasn't changed them. Yeah? So I think the first one's showing actions of parathyroid hormone. The second one's showing vitamin D3. But if you combine the two diagrams, you actually get this. Now, this seems absolutely horrible to look at, but it actually kind of makes sense. So if you look at something like this here, so this is showing low calcium levels. You can follow the arrows and see that, firstly, it's going to activate the parathyroid glands. These glands will then cause calcium and phosphate resorption from the bone. And at the same time, they'll work on the kidney to increase calcium reabsorption. But this dotted line is showing inhibit, so it's going to inhibit phosphorus reabsorption. At the same time, it's got an arrow going towards this enzyme that's going to help convert vitamin D into its active form. Once converted into its active form, this vitamin D, if we follow the red line, is going to help increase GI absorption of calcium and phosphorus. And at the same time, it's going to help with that bone resorption as well. Make sense? And then you can follow that for hypercalcemia as well, with the dotted line where you actually get things that are being inhibited. Does that make sense? So this diagram is like very full on, but if you can follow the lines, then you're pretty much set for the exams. Like that's maximum amount of detail you'll need to know about this. Cool. Yeah? Any questions there? All good?
You explain how like vitamin D
Mm-hmm.
affects the bone, but it causes bone breakdown. Vitamin D causes breakdown.
So it's important for regulation. So at the same time, vitamin D, yes, it does increase bone resorption, but at the same time, it also helps decrease parathyroid hormone levels, if that makes sense. So then all of that together helps kind of stabilize how much bone you're depositing and how much bone you're resorptioning. I know it doesn't make sense because obviously it's causing bone breakdown, but generally when people say vitamin D3 is great for bones, they kind of mean it's great for bone metabolism, if that makes sense. Yeah? Yeah. Yes. Yep. So what happens is the bone is going to release both calcium and phosphorus, and the kidneys are going to get rid of phosphorus, but going to absorb calcium. Overall, a net effect of parathyroid hormone is that you're going to get a lot of phosphorus excretion in the end, even though you're going to get released from bone. But at the same time, that's why vitamin D, once again, is super important, because then vitamin D is going to help restore those phosphorus levels because they help reabsorb phosphorus from absolutely everywhere. Make sense? Cool. Any other questions? Cool. All right, so moving on to diabetes stuff. So beta cells in the pancreas can detect when blood glucose levels increase. And in response to this, they secrete something called insulin that inhibits lipolysis, gluconeogenesis, and glycogenolysis. Instead, it ends up promoting lipogenesis, glycogenesis, and glucose uptake by cells. These actions overall lead to a reduction in blood glucose levels. Conversely, if there's too much sugar, we're going to get activation of alpha cells in the pancreas that secrete glucagon. So this pretty much has opposite effects. So we're going to get glycogenolysis and gluconeogenesis. And these lead to an overall increase in blood glucose level. Make sense? So these two hormones are super important because they help like maintain that delicate balance of blood sugar levels. And so if things go out of whack, you can actually give people insulin or glucagon to fix their levels. So in diabetes, too high sugar, we can give them a bit of insulin. And if we have someone with a hypoglycemic attack, we can give them glucagon to try and increase their blood sugar levels. Cool. Histology. How good was endocrine histology? Oh, okay. Anyway. Jason, do you like histology? Oh, that's okay. Once again, no trick questions. Which endocrine organ contains pituitary? Yeah, good job. See, there you go. They're getting harder, aren't they? So there's 3 types of cells present in the anterior pituitary. I really hope you guys histology after this because honestly, endocrine histology makes so much sense. But we'll see it. Oh, I'm so excited. Okay, so we're gonna have chromophobes. These guys are poorly stained on slides, and they actually appear a little bit whitish. Basophils. So these guys come up. They say deep pink, but I think it looks more purple. And they produce TSH, ACTH, FSH, and LH. And lastly, acidophils, which turn up a pale pink, and they produce growth hormone and prolactin. I don't know if someone's introduced like, I forgot, I think it was AGP. I think that's how some people remembered it. So AGP, so acidophils secrete GH and prolactin. Everything else is done by basophils. I think that's what they used. I never used it. I don't know. I just remembered it, but it's up to you. But you can use AGP to remember that acidophils secrete these two. In contrast, our posterior pituitary, remembering from the embryology that it actually contains nervous tissue and neural axons, is composed of something called pituocytes. So these are neurosecretory cells that will secrete that ADH and oxytocin. Great. So this is what. Blurry. That's a little bit blurry. Okay. Well, I apologize for that. It's a little bit blurry, but as you can tell, so just looking at this, you can tell it's the anterior pituitary because it's very colorful. That's the first thing you'd notice. So all these super purple things, these are basophils. All these lighter pink things are acidophils. And all these almost whitish things are chromophobes. See, not hard. Does that make sense? Yeah, perfect. And do you remember what acidophils and basophils are secreting? Growth hormone and prolactin for acidophils, everything else for basophils. Yes. Yes, yes. So when I say pale pink or purple, I mean the cytoplasm. Sorry, I should clarify because the nucleus will look purple. Does that make sense? See, not bad at all. See, look. So chromophobes, all good? Okay, so once again, for anyone, acidophils, they appear a lot more pink, and they're going to have all those other hormones that basophils don't. Let's just say it that way. And basophils are going to be the super purple ones. So that's all of these guys here. That's a basophil there, and chromophobes that they're just a lot more whitish. Make sense? There's some capillaries there. Do we know what is this red stuff inside the capillary? Did someone say blood? There you go. Perfect. Yeah. So that's just blood there. And they look like red blood cells. See, it's not hard. It makes sense. Yes. What do you mean, the parvo? Yeah. Yeah. So that's in the posterior pituitary. This is the anterior pituitary right now. Does that make sense? Because remembering that growth hormone, prolactin, LH, FSH, TSH, all of that is secreted by the anterior pituitary. And so when you take a slice and you see something very colorful, it's probably the anterior pituitary because it's secreting all these different hormones from acidophils and basophils. But great segue because the next thing we're going to look at is posterior pituitary. Now notice automatically this looks super bland. And that's because all it really has is pituocytes. And all of these kind of cells here are pituocytes. And that's kind of mainly what the posterior pituitary contains. And this is what's secreting all those oxytocin and ADH. And all these little wavy lines in the middle, these are actually axons. So these are all the axons that are coming down from the hypothalamus that's ready for that secretion. Does that make sense? Yeah? Few nods? Perfect. Oh, you can see a herring body as well. That's nice. Do we know herring bodies? Herring body is like the end of the axon. It's like the terminal bit where the actual chemicals is actually going to come out of, where the oxytocin and ADH will come out of. So that's a herring body. It's like the terminal end of the axon. So I think that's a herring body there as well. Yeah, oh, how cute. Do we know what that is? What that is? Slightly red. So Jamie mentioned it before. Blood. Did you say blood? Yeah, perfect. So this might be a capillary where you've got blood. Make sense? Cool. So this is something I took out of Meta's histology, simply because he had a really good summary diagram. And you can see anterior lobe, very colorful, full of basophils, acidophils, and chromophobes. And here we've got posterior, a lot more bland, and that's because it's got pituitary, really. And you can see that clear demarcation here, where this is posterior, this is anterior. So thyroid histology gets even more interesting, where it actually has numerous cavities known as colloids, and this is where thyroglobulin is actually stored. So each cavity is surrounded by follicular cells, and these are the guys that are actually making that thyroid. They're simple cuboidal cells, epithelial cells, and they are making that thyroglobulin, secreting it into the middle, and then remembering from how thyroid hormones are made, these thyroglobulin molecules are then iodinated, taken back into follicular cells, and then secreted wherever they need to be. At the same time, you might also see some clear parafollicular or C cells, so they're all the same thing. And these actually secrete calcitonin. Calcitonin is not too clinically significant. It can be measured as a tumor marker for some types of thyroid cancer. It can actually be given as treatment for Paget's disease as well. But I guess for now, just know that C cells secrete this thing called calcitonin, but it doesn't become relevant until much later on in the course. So the thyroid actually looks beautiful, where we've got that colloid in the middle, and it's very distinct. Like you'll look at thyroid and be like, yep, this is thyroid. And you'll see that there's this massive space in the middle that has all this thyroglobulin. And remembering that our thyroid hormones actually go into the cell, into the nucleus to actually work whatever they need to do, that makes sense from this diagram, because remembering that fat actually comes up quite clear. So that means we're expecting these thyroid hormones to be quite lipophilic. And we can see that in this histology slide. We can see how clear the thyroglobulin is. And that's why the function of thyroid hormones and where they go to act also makes sense. Then we can see that they're surrounded by this simple cuboidal layer of epithelial cells, the follicular cells, and they're the ones that are secreting this into the middle and then taking it back. And then here we can see this is a clear cell or a C cell, and it's literally a little bit more white, a little bit more clear. Make sense? See, histology isn't that bad. Yes. Here in the middle, I'm actually not too sure. That might be some sort of vessel. That might be some sort of axon. I'm not 100%. But yeah, good one to look up. I actually don't know. Yeah. Great. And then once again, this is the summary diagram that I took from Neda's histology, where you can see this thyroid has a very distinct shape of little cavities everywhere. Cool. Adrenal histology. This one's not as mentioned as much and often doesn't turn up as much in your exams, but I've covered it just to be sure. And we're just going to go through the 5 layers. So we have the capsule, which is that fibrous tissue. We have the glomerulosa regulating salt levels, fasciculata, glucose and androgens, reticularis, glucose and androgens, and lastly the medulla, which has chromaffin cells that are secreting adrenaline and noradrenaline. So if we look at adrenal histology, we'll see that this is the capsule. This is the periadrenal fat kind of thing, because it's coming up white, so we know it's fat. Capsule, it's quite fibrous, and we can see the wavy collagen. We can see the glomerulosa here. It's quite well demarcated from this fasciculata in the middle, and then a reticularis at the end. So that's kind of the amount of detail that I covered histology and for the adrenal glands, just knowing that they actually look quite different. And then lastly, you're going to see a demarcation zone between the cortex and the actual medulla. So the medulla, once again, becomes quite clear, and you can see that here. Make sense? So all the different layers you'll actually see in the histology slides as well. And once again, Aneta's diagram that kind of summarizes it, and you can see it very clearly over here. Sound good? Any question about adrenal histology? Nope? Great. Is that okay with histology? Is anyone still like, I absolutely can't deal with histology, or anyone has pressing questions about any histology? It looks pretty under the microscope, doesn't it? It's like a whole new world. But anyway, Sam, is Sam here? Oh, Shanae, you can answer it then. So, your question is, in diabetes, which hormone loses its normal function? Yeah, perfect. Insulin. There you go. Yeah. Okay, so we'll start with diabetes. So diabetes is, it's important to have diabetes down pat simply because it's relevant both clinically and for your exams. In diabetes, the body is unable to transport glucose into cells and producing high levels of glucose in the blood instead. So that means we're going to end up with that hyperglycemia. As we discussed, the hormones here involved are insulin and glucagon, which are produced in the beta and alpha cells of the islet of Langerhans. So type 1 diabetes, this is a type 4 hypersensitivity response where T cells of the immune system start attacking the body's own pancreas, and that leads to damage of the beta cells, and thus insulin can no longer be produced in adequate amount to transport that glucose into cells. Clinically, this presents as a triad of polyphagia, and that's because we're going to have weight loss since glucose can't be used for energy, and so the body starts breaking down other proteins and fats to kind of get its energy. Polyuria, because glucose leaks into the ultrafiltrate of the kidney and exerts its osmotic pressure and drags water with it. And lastly, polydipsia, because you're going to get all that fluid loss, so you're going to want to drink more water. These patients are placed on lifelong insulin therapy to control their diabetes, and that makes sense because we've studied the physiology now. Insulin will help decrease their blood sugar levels. So diabetic ketoacidosis, one of the major complications of type 1 diabetes is DKA, which is when mobilized fatty acids and proteins are converted to ketones to be transported around the body, but ketones by nature are quite acidic. So high levels in the blood can produce an acidosis. And these patients generally present with three things. So you get cosmal respiration, which is when they breathe quite heavily to let all the CO2 out. And you would have done this physiology and biochem with Professor Wright, and he would have talked about how CO2 can turn into acid if it's retained in the body. So if you get rid of it more, you're going to end up increasing your blood pH. And since in DKA, we already have a reduced pH, if we breathe more, we can try and bring our pH back up. At the same time, we have hyperkalemia. So I have this diagram on the right that kind of helps illustrate this. Pretty much imagine that this is the blood vessel and this is the cell. And let's say like normal for the blood is 1 H plus ion, so that's the blue one, and 1 potassium. So in this case, we can already see there's a slight acidosis. We have 2 hydrogen ions. And so pretty much we have transporters in the blood that can exchange potassium for hydrogen. And here, now we can see we've got too much potassium because we said 1 potassium in the blood is considered normal. This is where insulin works. So insulin can not only transport glucose into cells, but can actually also help exchange sodium for potassium. So now we've got a normal level of hydrogen and potassium in the blood. And that's what happens in someone who's healthy and they have a slight acidosis. What can happen in DKA is that you have severe acidosis. And so you're going to exchange all your hydrogens for your potassium, and yet you actually still won't be able to achieve a full normal pH because you still have too many hydrogen ions left. But now at the same time, our insulin doesn't work. So when insulin's gone, we can't transport our potassium for sodium. So we end up with all this, we can't transport our sodium for our potassium. So we end up with all this potassium in the blood and not in the cell. And so we end up with hyperkalemia. Does that make sense? Does anyone want me to run through that again? Yes, perfect. So let's say normal in the blood is 1 hydrogen ion and 1 potassium. So in this scenario, we can see we only have 1 potassium, but we have 2 hydrogens. We'll swap the hydrogen for a potassium. Insulin will come in, and insulin will stop the sodium for the potassium. So now homeostasis is restored. We have 1 hydrogen, 1 potassium. We're all good. In DKA, we have too much of an acidosis. We have too many hydrogen ions. We tried to exchange them all for potassium. It kind of worked. It helped bring the pH up slightly, but we still have some hydrogen ions left. And our insulin is not working because we're a type 1 diabetic. So insulin's gone. And so that means our potassium can't be exchanged for our sodium. And so we end up with lots of sodium in the blood that presents as hyperkalemia. Does that make sense? Yes. We'll get into that. Yeah, that's a very good question. Great. So because we have hydrogen ions left in the blood, we're going to have metabolic acidosis. And if you measure that anion gap that Chris Wright absolutely loves, we're going to have a high anion gap, if that makes sense. Sorry. Yeah, a HAGMA, high anion gap metabolic acidosis, yes. So it's important to note that DKA can also occur not just in patients that have poorly controlled diabetes, but also in states of stress when the body requires a lot of glucose suddenly. And because our insulin doesn't work, we can't get that glucose, so we go into DKA. So things like infection can also cause DKA in patients with type 1 diabetes. Great. So treatment of DKA is a perfect segue. So first thing we're going to do is give them fluids because they're going to be so dehydrated because all that blood glucose is going to drag water out of cells. So the first thing we want to do is give them fluids. The next thing we want to do is give them insulin. Are we good? Okay. As soon as we give them insulin, remembering from that slide that we had previously, that insulin is going to go into cells, transport glucose, but at the same time, exchange all this potassium that's been sitting inside the bloodstream for sodium. So all that potassium is going to suddenly rush inside the cell. So then when you measure the blood potassium levels, they're going to be low again because all of them have gone inside the cells. Yes. You can give just regular normal saline, I think. I'm not 100%. I would just give them normal saline because, to be honest, they have all the energy stores already. All you have to give them is insulin and fluids, and they should be okay. But I'm not 100% on that. When you give them insulin. Because remember, yeah, because remember how insulin will help do this thing here. So if you give them insulin, all this extra potassium that's sitting out in the blood now is going to go through the insulin and end up inside the cell. And I've written monitor electrolytes because you might give them potassium, or if you notice that what can happen is when you have the hyperkalemia, when all this potassium goes through your kidneys, if you have a hyperkalemia, the kidneys are going to also excrete more potassium. So at the same time, when you excrete all this potassium out and you've given all this insulin, your potassium levels can really, really drop, which is why you might give them potassium. But at the same time, you want to just monitor it. I haven't written give electrolytes because sometimes you give them insulin and the electrolytes will just normalize on their own. Sometimes they won't. So you've got to monitor them and in most cases give them potassium. Does that make sense? Yes.
Hypernatremia.
Yeah.
So if they're hypernatremic, can you give them like lots of like you're on the
Mm-hmm.
Does the same thing happen? Like give too much potassium or decrease it too rapidly?
Yeah. Yes, something can definitely go wrong. So that's an amazing question because potassium and sodium can both be quite lethal if they're in the wrong amounts in the body. So sodium loves to screw up the brain. So high sodium, low sodium will affect fluid levels in the brain. If you have too much sodium in the blood, it's going to drag all this fluid out from the brain and it's going to dehydrate the brain. If you have too little sodium, all that fluid is going to go inside the brain and cause cerebral edema. With potassium, though, potassium is regulated by the brain independently. The brain doesn't care what the potassium levels of the blood is, it regulates it by itself. Instead, potassium affects the heart. So that would have been covered in your DG labs or your interactive active learning sessions, whatever they're called. And your potassium can affect heart function. So that's the other reason why we're monitoring electrolytes so heavily here. Because if they end up hyperkalemic, your cardiovascular system is going to go downhill very, very fast. Make sense? Amazing question. Any other questions? Perfect. Does this all make sense? Great. Okay, moving on to type 2 diabetes. So this is when there's sufficient insulin, but the tissues for some reason develop some sort of insulin resistance that stops the hormone from actually working on the tissues. There are various risks associated with the disease, particularly obesity, genetics, and lifestyle factors, stuff you would have heard of already. But pathophysiology of type 2 diabetes is quite complex. So since there's insulin resistance, the body actually makes more insulin to ensure that the glucose is actually entering the cells, causing hypertrophy and hyperplasia of those beta cells. These beta cells then produce amyloid, which is kind of like a toxic substance, and that can eventually cause atrophy and hyperplasia of the beta cell. So the beta cell kind of pranks itself where it starts making like a heap of insulin and starts hypertrophying and making more of itself. But then it produces this toxin at the same time, which ends up killing the beta cells in the end. Now, eventually, you're going to have non-functioning beta cells once they atrophy, and by this stage, this is when you have the severe type 2 diabetes. So generally, patients will present before they reach this stage, but often you will get some patients that have very poorly controlled diabetes, and it's especially bad because not only do they have insulin resistance, but they're also cut their pancreas now because it's completely dead from the amyloid. Make sense? Cool. Similar to DKA, the people with type 2 diabetes can get something called hyperosmolar hyperglycemic state, so HHS. And this is when hyperglycemia is so severe, it literally pulls out all the fluids from the cells through osmosis, leading to life-threatening dehydration. Yes? No, surprisingly, for some reason, it doesn't. I don't think it does. I haven't heard of it affecting exocrine function. Good question, and I don't know why it doesn't. But it probably because the islets of Langerhans are quite separated from the exocrine cells. So there's probably something that contains that amyloid being produced. But yeah, for some reason, exocrine function remains. If you have something like cystic fibrosis, that's when the entire pancreas is going to be affected. So that's when both exocrine function and endocrine function kind of don't go as they should. And that's why people with cystic fibrosis can end up with diabetes as well, because they don't have insulin. Great. Moving on to complications of diabetes. So other than DKA and HHS, there are actually various vascular and neurological complications that you guys would have heard of, hopefully. I think you got an extra lecture this year on this sort of stuff. And generally, it's really important to know these because generally patients will be asymptomatic when they present with diabetes. So these complications result from hyperglycemia causing vessel damage because the high blood sugar levels can induce pro-inflammatory responses. And these processes eventually cause three things. So hardening of the capillaries, hypoxia, and lastly, atherosclerosis. So all of these then lead to your complications of micro and macrovascular stuff. So retinopathy, damage to the eyes, neuropathy, specifically affects peripheral and autonomic nervous system. So have you heard of glove and stocking distribution neuropathy? Yeah. So you're going to get that. You're going to get erectile dysfunction. That's part of the autonomic nervous system. And nephropathy, so damage to the kidneys. Macrovascular complications, you're going to get cardiovascular events. So things like your ischemic heart disease, cerebrovascular events, strokes, and peripheral vascular. That's things like ulcerations, gangrenes, poor healing, that sort of stuff. Make sense? Any questions about diabetes? Okay, so move on to pituitary pathologies. Now, I don't think I mentioned this. This is one of the few exams you'll get where it'll actually be very clinical. They'll ask you more questions about pathologies than they will about the actual nitty-gritty physiology bits, which is why I'm focusing a lot on pathologies right now. Yes? So I watched this osmosis video that kind of tried to explain it. I don't know if they gave you the same one for your DigiLab, or it might have been the Armando Hasalundan guy. I don't know how to say his name. But pretty much, they talked about how apparently adipose tissue can cause inflammation of some sort. And this inflammation causes insulin resistance. And so when you lose weight, this kind of inflammatory process also dampens down and your resistance goes down as well. Once again, I don't know if I certainly don't know why this happens on a molecular level, but I don't think anyone does. Like, I think that's still being researched because if they knew, they would have developed some sort of drug for it. But yeah, there is definitely this kind of correlation where if you lose weight, the resistance goes down. I have no idea why that is, but I'm assuming it's something to do with the inflammatory process that adipose tissue has on creating that resistance. Make sense? Perfect. So moving on to pituitary pathology. So you can get something called a pituitary adenoma, which is enlargement of the pituitary gland. And that can lead to this like local mass being formed that's quite functional. So it can secrete a lot of hormones. So there's three kind of main categories of signs and symptoms. Hyper and hyperfunction. So that's when you have too little or too many hormones. But at the same time, you can get something called bitemporal hemianopia. Has anyone heard of bitemporal hemianopia? So when you have a pituitary adenoma, remembering that the pituitary gland is located right next to something called the optic chiasm. Now, you'll study this optic chiasm in great detail when you do head and neck anatomy, but pretty much this optic chiasm is involved with normal vision function. And so when you get enlargement of this pituitary, it can compress on this optic chiasm, and that can cause something called bitemporal hemianopia, which is when you lose peripheral vision. So you only see stuff in the middle, you don't see anything in your peripheral vision. I should have included a picture, but maybe after the lecture I can just Google image it for you. But yeah, if you see that, think pituitary adenoma. A specific type of pituitary adenoma is a prolactinoma, which is when you get increased level of prolactin. And some of the buzzwords associated with this are amenorrhea for women, erectile dysfunction for men, and loss of libido for both sexes. So if you notice that this question is discussing amenorrhea, erectile dysfunction, and loss of libido, think of prolactinoma. If you notice that it also has thyroid changes, adrenal gland changes, Cushing syndrome, all of that sort of stuff, it might be a pituitary adenoma instead, because there's multiple hormones being affected, not just a prolactinoma. A prolactinoma refers specifically to prolactin. Yeah? Cool. Other pituitary pathologies, so we can have something called panhypopituitarism, which is deficiency of most or all pituitary hormones, and you'll notice that in the signs and symptoms. Diabetes insipidus. Has anyone heard of diabetes insipidus? Oh, perfect. Okay, good. So this is when you don't have enough ADH being secreted, and so you're going to excrete a lot of water in your kidneys. So that means you're going to get polyuria, and because you're getting rid of a lot of fluid, polydipsia to replenish all the fluid you've lost. Syndrome of inappropriate ADH secretion, commonly abbreviated to SIADH. This is kind of like the opposite of diabetes insipidus, where you get too much ADH. So what can happen is you're going to get hypervolemia. So this is from too much water absorption in the kidney. Hyponatremia, because all the salt in the body gets diluted. And you end up with hypotonicity, because once again, your electrolyte concentrations have gone down because you've absorbed all this water. Definitive treatment for your pituitary pathologies is something called a transsphenoidal surgery, which is kind of like when they put something up your nose to try and like take out bits of the pituitary that aren't working right. And once again, there's different clinical presentation of pituitary pathology. So this is panhypopituitarism, where you can see they kind of have loss of axillary hair. That's probably because of reduced androgens. Low blood pressure, because they probably have not enough aldosterone, so they're secreting all the fluids out. They probably have, what else do they have? Yeah, oh, so they have a lot of skin stuff. So they have dry skin. So dry skin could be because of the hypothyroidism. They don't have enough TSH being secreted, and therefore they're ending up with reduced thyroid hormone levels, dry skin. So notice that everything from all the hormones is being affected in these patients. This is an interesting one because this is showing what can happen in panhypopituitarism, where there's apparently a grown person who didn't have any androgens or growth hormone, so they were kind of small and still look quite babyish, whereas this person received growth hormone but didn't receive androgens. So they look like a big child, if that makes sense. They never had that sexual development. So you can have different versions of pituitary adenomas or pituitary insufficiencies, and different hormones can be affected. Looking at growth disorders now. So we can have two types of main excess growth hormone disorders, and that's gigantism and acromegaly. So gigantism occurs if you have too much growth hormone during childhood. Acromegaly is when it's during adulthood. There's a whole range of signs and symptoms you want to look for someone with excess growth hormones, but the main stuff you want to concentrate on are the stuff listed here. So for children with excess growth hormone, so gigantism, they're just going to be big, like overall, everything's going to be big. Whereas adults, they're generally going to have bigger hands and feet, and something called prognathism. Does anyone know what that is? It's like when their jaw kind of protrudes out. So it's kind of like this here. So the jaw kind of goes like out. I don't know how to do it, but yeah. So This is gigantism here, and this is acromegaly here. Make sense? Any questions? Cool. And then you can have insufficient growth hormones or problems with other receptors that help with growth. So leprechaunism is when you get insulin receptor defects. So remembering that insulin is super important for growth as well. We can get something called leprechaunism. And then there's laryngealism, which is when we have defective IGF-1 receptors. Now, if only IGF-1 is affected, generally they can still develop into normal functioning people, because what can happen is that growth hormone is still able to act on other peripheral tissues, but IGF-1 is missing, so their bones don't lengthen and they don't grow. So they end up as short but functioning people. And I just thought this was interesting. Apparently, they have anti-aging effects, so they're less likely to get diabetes and cancer. So I guess there's a silver lining. Thyroid and parathyroid pathologies. So terminology is super important in pretty much all of endocrinology because they mean very specific things. So primary refers to a pathology at the level of the gland itself, whereas secondary refers to a pathology at the level of the controlling hormone. So for example, in here, if we have primary hyperthyroidism, the primary tells me that the problem is with the thyroid gland itself, and the hyperthyroidism tells me that it's hyperfunctioning. There's too much of thyroid hormone. Whereas secondary hypothyroidism tells me that because it's secondary, the pathology is at the level of the pituitary, and hypothyroidism tells me that it's underproduction of thyroid hormone. Does that make sense? So anytime you have someone that comes in with a suspected thyroid pathology, the first thing you want to do is a thyroid function test for them. So that involves measuring T4 levels and TSH levels. And so if we work through this, we can have primary hypothyroidism. There's too much T4, but the pituitary is working fine. So that negative feedback loop is going to decrease TSH levels. Secondary hypothyroidism, the pituitary is not working. So they're going to increase too much. It's going to release too much TSH, and that's going to stimulate T4 production. So T4 will be increased as well. And then kind of the opposite, primary hypothyroidism, pituitary is working fine, but T4 levels are quite low. And so the pituitary will detect that and start secreting a lot of TSH. And secondary hypothyroidism, the pituitary is not working, not enough TSH, so not enough T4 is produced. Does that make sense, this table? Perfect. And then you've got clinical presentation. Now, I'm not going to go through each one, but the people from the OSCE night will know that I have these acronyms, thyroidism and fair chimps, for hyper and hypothyroidism. But I reckon if you can go through the clinical features and kind of reason why they get these things, then that means you've been able to kind of understand the physiology and clinical knowledge behind these conditions. So, for example, if you can think of heart rate, that's because you're going to get too much T3, T4. It's going to act on the heart. It's going to cause a tachycardia. Whereas if we look here, intolerance to cold, that could be because we're going to get reduced thyroid function, and that means lower basal metabolic rate, therefore less likely to produce body heat and more intolerance to cold. Cool. And then these are just pictures showing what each of the people will look like. So someone with Graves' disease will look like this. Someone with hyperthyroidism will look like this, and hypothyroidism will look like this. And you guys can go through the labels in your own time. So there can be different causes for each of these thyroid pathologies. So hyper and hypothyroidism simply describe a state that the patient's in. So hyperthyroidism, the main three things that can cause this is Graves' disease. So that's when you get antibodies that actually stimulate the TSH receptors on the thyroid itself. Toxic nodules, so these are just kind of little adenomas on the thyroid that are functional. So they end up just hypersecreting all these thyroid hormones. And lastly, something called subacute thyroiditis. So that's inflammation of the thyroid. And what happens is because we get destruction of this thyroid tissue, all these preformed thyroid hormones get released into the bloodstream, and that causes an initial hyperthyroidism kind of picture. But then eventually you're going to get destruction of this thyroid, you're going to get release of all those hormones, and they're going to eventually get metabolized and finished up. And that's when you'll experience a hypothyroidism kind of picture. So that one's interesting because it switches between the two. Hypothyroidism, on the other hand, mainly is due to iodine deficiency, and that's because then the thyroid can't produce the thyroid hormones. Hashimoto's thyroiditis is kind of the opposite to Graves' disease, where you get antibodies that, once again, attach onto those TSH receptors on the thyroid gland, but they end up blocking the receptor rather than actually stimulating it. And lastly, iatrogenic. So this is kind of sad, but often in thyroidectomies or hyperthyroidism, if you remove too much of the thyroid, you can end up with hypothyroidism, which is kind of funny, I thought. And then there's drugs as well. So amiodarone, radioactive iodine, and particular contrast, all of these can interfere with the iodine balances in the body and therefore can affect thyroid function. Parathyroid disease isn't covered too much, so I've kind of popped it all in one slide. But pretty much, since parathyroids regulate calcium levels, any pathology associated with this gland can cause calcium imbalances. So hypothyroidism refers to parathyroid overactivity, and this can be of various types. You can have primary, that's when there's just too much parathyroid hormone being secreted. Secondary, which is when there's a ridiculous amount of parathyroid hormone, but that's being secreted because there's something in the body that's causing hypocalcemia. So that could be some sort of deficiency. It could be chronic renal failure. So you guys would have studied in renal failure. You don't get that vitamin D activation happening, and therefore you end up with shitty bones. Therefore, you're going to have increased PTH. And lastly, tertiary hypothyroidism. That's when you get long-standing secondary hyperparathyroidism that causes a permanent increase in the parathyroid gland's ability to secrete PTH. So PTH is going to be secreted even if that problem that was causing that initial hyperparathyroidism is fixed. Hypoparathyroidism is underactivity, and most commonly this is because of a thyroidectomy. So this is when the surgeon goes in, takes the thyroid out. But remember how those parathyroids are at the back, kind of hidden away. So they can sometimes inadvertently damage them or remove them as well. So the patient, after they come after the operation, they end up with all this like calcium imbalances because their parathyroids got damaged in the process. Hypercalcemia. I don't know if you guys have heard of stones, bones, moans, and groans. These are the 4 classic signs and symptoms you see in hypercalcemia. And hypocalcemia, you're going to get that Schwaff's text sign and the Trousseau sign. So that's the nerve tapping one and the blood pressure one. So you get that carpopedal spasm with the blood pressure one. And with the tapping of the nerve that runs kind of in this area, you're going to get twitching of the face. That happens with hypocalcemia because your nerves get overexcited pretty much. It's not going to work on you, Harsh. Are you hypercalcemic right now? No, might not work. Cool. Adrenal pathologies. So these will tend to turn up quite a bit. First one I'm going to discuss is adrenal insufficiency. And this is when you have inadequate cortisol levels and or aldosterone production. And when this is primary adrenal insufficiency, so the problems with the adrenal glands itself, it's termed Addison's disease. The clinical presentation of Addison's disease is what I call damp fawns. It doesn't make much sense, but yeah. And the main things you want to note from that is this mysterious abdominal pain you get, postural hypotension. And that makes sense because if we don't have aldosterone, the salt and water isn't contained in the body. So you end up with really low blood volume and therefore hypotension. You're going to get weight loss because you don't have cortisol, so you won't have all that deposition of all that adipose tissue. Salt craving, once again, because you don't have that aldosterone, and skin changes. So this can be lighter or darker, and I'll explain why. Because you don't just have Addison's disease, you can also have secondary adrenal insufficiency, and that could be due to a pituitary issue. Remembering that ACTH can act on melanocortin-1 or melanocortin-2 receptors, depending on the type of pathology it is, we might have light or dark skin. So in something like Addison's disease, the pituitary is working fine, but the adrenal glands are not secreting enough of the hormone. So ACTH levels are going to go through the roof because there's going to be no negative feedback. That ACTH can then act on both melanocortin-1 and 2 receptors, causing dark skin. So people with Addison's will have skin hyperpigmentation. People with secondary adrenal insufficiency, so let's say if the pituitary is unable to secrete ACTH, if there's no ACTH, then it won't act on the melanocortin receptors. So they'll end up with pale skin instead. Does that make sense? So these guys can present differently, and that's how you would differentiate between someone primary or secondary adrenal insufficiency. Hypercortisolism is just another word for Cushing's syndrome. So there can be, once again, different terminology where Cushing's disease refers specifically to an ACTH secreting pituitary adenoma. Now, this is the classic picture of someone with Cushing's. And once again, clinical presentation, there's a whole range of things you want to look out for, but mainly is stuff like hypertension, immunodeficiency, hyperglycemia, central obesity. And this all makes sense if we go back to the actions of cortisol. So central obesity, obviously coming from that cortisol deposition of adipose tissue in the central areas. But at the same time, hypoglycemia, because it mobilized all those energy stores to push glucose into the bloodstream. Osteoporosis, remember how it acted on the bones, so that's going to cause bone resorption, and they're going to end up with poor bones. Hypertension, because all this cortisol can act on aldosterone receptors, so the mineralocorticoid receptors, and cause increased retention of salt and water, so they're going to end up with high blood volume and hypertension. And immunodeficiency, because remember one of the hematological effects of cortisol was to dampen down the immune response. Does that make sense? This is why we're ending up with this sort of picture. And remember how we discussed that we do get mobilization of fats, but it's kind of in the arms and legs. Notice how this person has great amount of obesity centrally, but the arms and legs are quite skinny. And that's because all the fat has been mobilized from that area. Make sense? If you go back to the physiology, the clinical picture kind of makes sense. So investigations are super important for any sort of Cushing syndrome, and that's because we want to identify what's causing this cortisol increase in the blood. So I'm just looking at the time. Okay, perfect. So looking at a dexamethasone suppression test, we kind of look for 4 things. So a dexamethasone suppression test is pretty much measuring cortisol levels initially. If the cortisol levels are normal, then this person does not have hypercortisolism, and need to find other causes of their signs and symptoms. Is that a question? No? No? Perfect. All good. So if their cortisol is high, then you can consider diagnosing them with hypercortisolism or Cushing syndrome and then figuring out what it is. The next thing you want to do is measure their ACTH. If their ACTH is low, then immediately you're starting to think of an adrenal tumor, because the pituitary is working fine, clearly, because ACTH has responded appropriately and decreased while cortisol levels are still high. So we're thinking might be an adrenal tumor. If ACTH is still high, you can do this dexamethasone suppression test, where you give them a low dose of dexamethasone, which is a glucocorticoid. And if it's normal, we're going to get suppression of the amount of ACTH this person has. If they have Cushing's, adrenal tumor, or ectopic, this won't be suppressed because the low dose won't do anything for their negative feedback loops. If we give them a high dose of dexamethasone, the Cushing's disease will get suppressed, but the tumors won't. So if we end up with a picture of high cortisol, high ACTH, we can give them a high dose of dexamethasone, and if it's suppressed, we diagnose them with Cushing's disease. If it's not depressed, then we might look at ectopic ACTH tumor. And this refers to kind of tumors that end up secreting ACTH on their own. So kind of like lung cancers, they're really good at secreting ACTH just on their own. So that's kind of what this test does, and it kind of helps figure out definitively why or where their cortisol is actually coming from. Yes. Yeah. Yeah.
Why would high dose
It is a problem with the pituitary. The Cushing's disease is a problem with the pituitary, which is why in low dose, so generally the cortisol levels we have in the blood, that's being mimicked by this low dose. So this low dose is kind of like how much cortisol the blood would normally have, which is why it's not getting suppressed, because obviously this is a pathology and normal body levels of cortisol are not suppressing this particular type of disease. This high dose dexamethasone is ridiculously high, like it is super high amounts of cortisol, glucocorticoids. And so this eventually, because it's so high, it actually finally ends up suppressing a little bit of that pituitary disease. Yeah, there is a slight feedback loop there that will kind of help decrease the amount of ACTH you measure. Does that make sense? Has anyone covered this in your DG labs or your lectures? Okay, perfect. So someone's mentioned it. Good. Yes? The ACTH levels. Yeah. It's looking at whether the ACTH levels have been suppressed and consequently whether the cortisol levels have been suppressed. Cool. pheochromocytoma. So this is fairly rare, but once again, I've chucked it in for the sake of completion. This is a tumor of the adrenal medulla. So remembering that noradrenaline and adrenaline was secreted by the adrenal medulla, if we get a tumor in that region, we're going to get ridiculous amounts of these hormones being released into the bloodstream. And that's going to cause like your sympathetic nervous system kind of clinical presentation. So anxiety, hypertension, sweating, palpitations, flushing, all that sort of things. And then diagnosis is just made by measuring your catecholamine levels or the metabolites. Congenital adrenal hyperplasia. Have you guys done this to death? I feel like this was mentioned a lot in RU level. Yes? No? Oh, okay. A lot of people are saying no. Perfect. Okay. So this got examined a lot for us. I'm not really sure why, because it's fairly rare, but I guess it's good to know. So congenital adrenal hyperplasia refers to enzymatic deficiencies within the adrenal cortex. So I don't know how big this diagram is, but I'll try and point it out. Pretty much this is showing that we have cholesterol that's being synthesized into cortisol, into aldosterone, and into androgens. Now, what can happen is this 21 hydroxylase enzyme can become deficient in these people. So it's a congenital abnormality. And when this becomes deficient, you'll notice that this cholesterol is unable to become cortisol because it's being blocked here, because this enzyme is missing. At the same time, this enzyme is super important to make aldosterone as well. So the cortisol gets to about this stage where it makes this hormone here, but it's unable to progress onto making cortisol and unable to make aldosterone. So this 17-alpha hydroxyprogesterone starts to accumulate because this enzyme blocks further synthesis. Instead, it starts taking a different pathway and starts making androgens instead, because the enzymes required to make androgens are still present. So the precursor builds up so much, it gets shunted towards making androgens. So these people end up presenting with hyperandrogenism, hyperaldosteronism, and hypercortisolism. Does that make sense? Cool. So then the clinical presentation includes ambiguous genitalia due to the hyperandrogenism. So when they're born, because of so many androgens, you kind of get ambiguous genitalia, especially in females. You get salt wasting because they're dehydrated. They didn't have any of that salt reabsorption because their aldosterone is missing. And as a result of that, they can also end up with heart problems because if sodium is being excreted, potassium is being retained. So they're going to end up with hyperkalemia. Hypoglycemia from lack of cortisol, and once again, a whole lot of sexual development issues because of this hyperandrogenism. Does that make sense? Cool. Hyperaldosteronism. So as you can guess, this is when you have too much aldosterone. And the name for that is Conn syndrome. So this is primary hyperaldosteronism. And once again, your signs and symptoms are consistent with a hypernatremia and a hyperkalemia. So too much salt retention, too much salt excretion. And the complications include things like hypertension, arrhythmia, and alkalosis. So the body likes to become alkalotic when there isn't enough potassium around. And I don't know if you guys remember from your parathyroid hormone lectures, but in alkalosis, you end up with more calcium being bound onto plasma proteins. So it's not active as such, so you end up with a hypocalcemia. And at the same time, you're going to get polyuria and nocturia, and that's because all the kidney effects it's having. Make sense? That's Conn syndrome. Osteoporosis is, I think, the last pathology that I'm going to discuss. So this is a condition where you get reduced bone mass, microarchitectural deterioration, and bone fragility. And that's because you get an imbalance between osteoclast and osteoblast activity. So we do something called a DEXA scan to try and diagnose people with osteoporosis. Did you guys get a lecture on this? Yep, okay, perfect. Where you measure something called a T-score. So this is looking at the standard deviation of how great your bones are compared to other normal people. And if you're at negative 2.5, that means you're 2.5 standard deviations away from what normal bone should be like. And if you're at that stage, you're diagnosed with osteoporosis. There's a whole range of risk factors that can contribute to the disease. A lot of it includes firstly aging. So aging is the biggest cause for your osteoporosis, as well as menopause and vitamin D deficiency, calcium deficiency, alcohol smoking, and medications. Chronic steroid use, once again, that makes sense because of our physiology. Cortisol will help break down bone and cause osteoporosis. So those on chronic steroids will end up with conditions like osteoporosis as well. So pathophysiology is kind of complex, but it makes sense on the whole. Pretty much our bone is remodeled based on any mechanical stresses or hormonal influences it experiences. And you get osteocytes and osteoblasts kind of breaking down bone and depositing bone. But in osteoporosis, the communication between osteoblasts and osteoclasts is kind of rendered ineffective, where we have something called rank and rank L system breakdown. So osteoblasts entail rank L, which can bind to rank receptors on osteoclasts to activate them. So if you get activation of osteoclasts, you're going to break down more bone. So we have something called OPG, which is made by osteoblasts, and that actually helps reduce rank L activation, and therefore you're going to get less bone resorption. But when you get menopause, the estrogen deficiency causes overexpression of this rank L, and that means you're going to get more bone resorption. And this actually overrides the inhibitory effects of OPG. So that means you end up getting more bone destruction after menopause. At the same time, from normal aging, your osteoblast function kind of declines, but your osteoclast function kind of stays the same. So you're going to get reduced deposition, but the same level of breakdown. So that's also why your bones tend to get weaker as you get older. So because of this disequilibrium, you're going to get reduced bone quality and density. Does the pathophys make sense? Great. And so the clinical presentation, often they're asymptomatic, but they might present with height loss because of collapsed vertebrae and crush fractures. And at the same time, they might just present with multiple fractures. So hip, wrist, vertebrae, and humerus are the most common ones. Also, there's something called fragility fractures, which is when they say, oh, I fell and broke my hip, but the actual incident, what happened was that they were just standing, but their bones are so brittle, they sustained a fracture, and because of that fracture, they fell. So you have to be really careful with these patients because they'll say, I fell and broke my hip, but it'll actually be you broke your hip from just standing, and then you fell because of that. So there's two types of tests that you can do. There's a wall ossific test, which is kind of like where you measure the distance from the wall to the back of their head. And if this is more than 0, then you consider osteoporosis, and that's because of change in their spinal curvature. And lastly, a rib distance test, which is when you measure from the bottom of the rib cage to the top of their pelvic crest. Cool. Prevention is mostly just vitamin and calcium supplements, and they might have discussed this briefly in your lectures. Cool. So that kind of ends it for me. I've got practice questions, but it's the last of semester. Like, I don't know if you want to stay for this. I'll probably just give them to you instead. How does that sound? Perfect. All right. Thank you so much, everyone, and good luck for your exam.
Can I grab the USB off you with the PowerPoint?
Yep.
And then I'll just upload that. Thanks.